So welcome. Our next session is devoted to the specific area of eMental health. So in this whole area of demonstrating digital applications, we are now focusing on providing mental health prevention issues and therapy via digital platforms. My name is Silke Schmidt. I'm a professor of psychology and prevention at the University of Greifswald, and we are focusing on many different areas in terms of prevention, and digitalization is one aspect where we focus in the health and work area. So a few years ago, we asked ourselves from the societies of behavior change, whether psychological prevention and eMental health has already had an impact in practice and is delivered on a regular basis, or whether this is still something we would like to have. And we already concluded that there is a lot of evidence in this area. eMental health is a very challenging pathway for psychologists and psychotherapists because you can address many questions. The first question, how do we reach as many people as possible in various populations? So these technologies help us to reach more people than we traditionally assume. The second goal is how can we develop interventions that are at the same time effective and economical? How can we ensure a widespread transfer of interventions into routine care? And how do we make sure that our interventions are implemented in routine care in a way that it is in line with the theoretical background? And the final question is that interventions should lead to long-term effects in health of patients. So several politicians and stakeholders say online therapy in terms of mental health is the only way to fight the mental health crisis, with mental health being one of the biggest challenges in the society. Evidence is there. We have many different studies showing that digital interventions can be as effective as face-to-face interviews. This is not possible for all health conditions and for all disorders. We have different experiences. We do not have evidence at the moment for mental disorders and having a comorbid somatic conditions. So this is an area we have to work more on in the future, the comorbid conditions between somatic and mental disorders in the internet. Internet-based interventions are defined as treatments that are mainly delivered via the internet with at least some therapeutic task delegated to the computer. Though the specificity of eMental health is that the intervention itself is being delivered via mobile solutions. We have to discuss giving all the startups who tackle the area of mental health, where can we do therapy, but however, when it is better to switch off. Mental health has also been a way to address specific populations, such as people in the Navy or astronauts. So this is leading in very targeted areas. And one of the new challenges is that you do not speak with a therapist, but you can speak with a computer. He's just saying, I'm ready to listen 24 hours, 7 times a week, no couches, no medication, no childhood stuff, just strategies to improve your mood. This is what Bluebird does. We have a lot of data security issues, which are very specific in the area of mental health, because people deliver the personal experiences via the internet. This is what we have to address first. And the issue of big data and also genetic data should be of highest concerns in the area of mental health. We have to think of these three different stakeholders. The patient, how can I use the internet and the smartphone to improve my mental health? The provider and the society. And the interesting thing is, how do we address in different types of indications, disorders, the processes? How can we enable people to do something? How can we initiate processes and have something like a doctor-patient relationship? And most importantly, we also have to study whether outcomes in eMental health are better or as good as in regular care. So I would like now to introduce my discussants here. We have again a female session. We would like first to address some of the technological and legal aspects, and then with many startups and companies here show current experience and evidence derived from major applications and discuss some future challenges. So our panelists are Professor Galina Ivanova. She is from the Institute of Applied Informatics at the University of Leipzig, and I would like to introduce yourself. Everybody's giving a short presentation of his background. Thank you.
Hello. Okay, my name is Ivanova. I'm head of the interdisciplinary Center for Biomedical Data Science at the University of Leipzig, Institute for Applied Computer Science, and we're developing different applications which are sensor-based and which are supporting the therapy and diagnostics of different kinds of patients. So, go there. Okay. My talk is today about sensor-based systems for therapy support and self-management. In order to have a reliable diagnostics, therapy, as well self-management of patients and of patients suffering by different mental illnesses, we need huge amount of data. And this data are the basis in order to extract information which can characterize the behavior of the patients, and not only the behavior, also the different factors which can positively and negatively influence the behavior of these patients. Nowadays, there are different kinds of mobile technologies which can support the collection of this data and which can help us in order to close the already existing gap in this information. We have really informational gap and we have informational change which are incomplete. In order to get this data or this information, we need to collect data specifically, individually, each one day, each 1 week, each 1 month. And this is really not easy also with the existing technologies. We have different kind of technologies of mobile devices which are available now. One of them are the wearables, and the wearables could be different. We have different sensors which enter the consumer market, and these have the advantages that they are cheap, they are easy to obtain, they're comfortable, and they're unobstructive. Also, they have high compliance and acceptance. We can acquire continuously longitudinal data or long-term data of the patients. That means we can also acquire time-dependent data, which is called signals. And this is very, very important, not anymore only at home, in home conditions or at the hospital. We can acquire data in real-life situation, in the specific real-life situation. We have different kind of sensors which are available to us, and these are some examples of the bioparameters which we can acquire. I have here also the signals which are exactly acquired by me during these talks. We have, for example, physical activity, heart activity, electrodermal activity, skin temperature, sleep data, speech. On the other side, we have our mobile telephones, and we have different applications which are helping us, for example, using the sensors and the software which is embedded in this telephone, or using special questionnaires to collect data about the mood of the patients in the morning, in the evening, about its social activities, about its app usage, and of course about the whole device usage. Also, we need a lot of other information in order to interpret the information extracted from the sensor on from these applications. We need context parameter because, as I said, we are not anymore in predefined conditions. We are outside. That means we need to know about something about the weather, about the temperature, about the air pressure, about the ambient light, and so on. All this information should be bring together in order to extract information which is usable for the description, for the understanding of the behavior of our patients. On the one hand, we have these modern technologies which are also pretty complicated, and on the other hand, we have diseases like depression, and depression is really one horrible disease. 5.3 million people are suffering by depression only in Germany, and every fifth person suffers from a depression episode in the course of its life. We have more than 10,000 suicides. And here you see the key symptoms. These are sadness, low mood, loss of interest and pleasure, fatigue, or low energy. How we can measure this, how we can acquire about information about this. We have now, supported by the German Ministry for Education and building one new project which is called STEADY, sensor-based system for therapy support and self-management of depression. And we are working together with partners from medicine. I am from the area of computer science and data analysis, but we have here as partners the German Association Against Depression, and we have also as partners huge IT companies which are supporting now us with their infrastructure like Adesso, and we are trying to get all this information and also to combine context parameters, bioparameters, and behavioral parameters longitudinally, individually for each one patient in order to extract individual patterns characterizing his situation, and we try to predict also the behavior of these patients. Our system is already functioning. It is built according the very difficult German laws, and I can tell you, if you want a lot about sensor complication and how they can be used here in Germany, but at the end we have a nice system which is already functioning, and we have also our first patients, and we hope that in about 2 till 3 years we will have also nice solution for the patient suffering on depression. Thank you very much for your attention.
Thank you very much for giving us an introduction into a field where we also need to have objective data on the patient, because depression is a condition where we would like to integrate more data than just voice and speech, and this is one of the future developments. I think it's now good to hear some of the experiences from existing companies, and I would like to start with the Dutch experience. So I'm the only male, so maybe you would like to introduce yourself.
5, perfect. All right. Let me put this a little bit higher. My name is Joris Moolenaar from Karify. We're a company from the Netherlands, and what we do is we help mental health care providers to add a digital layer to their clinics. By doing that, what you do is you can do digital intakes, you can prepare sessions beforehand, but what you can also do is give patients during sessions some homework. And by doing that, you can achieve great results. But also, as my former speaker said, there's a lot of relapse in mental health care. So one of the biggest problems as well is that if you use digital health, what you can do is you can do relapse prevention online, where you combine face-to-face meetings with some online self-guided mental health. And that's what we do with Karify. So it's a cloud solution. You just go online, you buy it, and that's how it goes. So what we do is we support at the moment, we did more than 100,000 patients that we supported. At the moment, we do about 45,000 patients a month. And we're active for 500 types of mental health care providers and active in 4 countries. The great thing is we started this company a couple of years ago, and what we're seeing is that you can achieve really, really cool results in doing something digital on depression, anxiety, mood disorders, ATSD, actually across every spectrum of the mental health care DSM-4 scope. So, of course, with mental health, it's really important that you do research on the effects that you're trying to achieve. So we have about 26 publications of people using our product and RCTs on the effects. So great things we achieve for addiction care, for instance, is by doing digital intakes, we can reduce dropout rates with 20%. We also did treatments for anorexic behavior. There's a lot of relapse, for instance. And by doing relapse prevention online with Karify, we reduced the relapse prevention rate with about 70% in the first 12 months. And that's actually a quite large achievement if you look at anorexic behavior. The cool thing is that the technology is so advanced at the moment that you can just use it as you like. And by doing that, what we try to do is, as a provider, we help you to assist the journey of a patient. So we do not say that your life is just face-to-face meetings, but it's also partly digital. So what you're trying to achieve as a healthcare provider is add a digital layer in combination with your normal sessions. And by doing that, you get sort of the power from the internet, which is sort of enabling your patient to do more at home. Well, for the clinician, it's a way to view where the patient is going. So you see what the patient is doing, you can feedback, you can interact. And by doing that, you sort of take all these little steps along the way. So we do measurements, medical information tailored to the person's position or place in time. We do peer stories where other patients actually tell about their disease. And by doing that, you sort of extend the session that you have with your psychologist. And that makes it more effective. We support a wide range of treatments. So we do multiple age groups. We start at age group 14 up to 80 years old. And what we see is that depending on the severity of your mental illness, you can do really light forms of mental health care online. So it can be talking about, I'm not feeling so happy, some balancing your life, like more easy, which you get from your GP. But on the other hand, we also do more severe treatments like addiction care, where we do the whole treatment from intake to aftercare. And what we also discovered, which is really great, is that when you're treating a patient in mental health care, there's always the family who also has to endure all the issues around it. And what we do as a company as well, we make self-guided family programs. So you can do a low-cost delivery of healthcare for family members, which may not be included in the payment structure as you are as a provider. But you can offer these extra services. And so you get a sort of digital service in combination with your clinic. And in the Netherlands, it's really a big thing. And we also see now in a lot of other countries, it's starting to move onwards. And that's really interesting. And that's what we do with Karify.
Thank you very much. Maybe one question. What is the business model? You started that you are hospital-based. Yes. Is this also your business model to cooperate with hospitals? Huh?
Yes. What we do is we provide the system on a payment structure where you pay per staff member that uses the system, and patients are free of use. So you can treat multiple patients with just one account.
Thanks. Further questions later. So, Mrs. Weber, I would like to ask you to present. You're also CEO of a company called GET.ON, and maybe you introduce yourself.
Yes, thank you. Hello, everyone. It's a pleasure to be here today. My name is Elena Heber, and I would like to give you a little bit of background information about myself first and the GET.ON Institute before I move on to some more personal views on online interventions. So my personal background is in psychology and research, and I started off working in the field of eMental health in 2011, when hardly anyone in Germany actually heard about internet interventions, including me. And I was part of a large European-funded project on online interventions, where I completed my PhD. And early on, we started recruiting our participants with the help of health insurance companies. And when we finished our evaluations and found our interventions to be effective, we were urged to actually create structures in order to be able to continue offering the interventions that we have found to be effective. So the GET.ON Institute was born, and it was set up by former researchers of this university project. Up to today, we are working with several universities that we are partnering up, and also other partners include various health insurance companies and social insurance companies, and also our technical partner. We are offering our interventions in a variety of sectors, so for example, in clinics, but also as part of prevention projects, or in the occupational health management, but also in the psychosocial sector. The interventions that we have developed and are offering now are, for example, stress, depression, insomnia, panic, so anxiety, chronic pain, but also alcohol misuse, to name a few. And all of our interventions have been evaluated in randomized controlled trials, so that is to say the gold standard of efficacy evaluations, and we also have tested them for cost efficacy. Some of the interventions we have adapted specifically to certain target groups, for example, employees, or also for somatic conditions such as diabetes and depression, or chronic pain and depression. Our GET.ON stress intervention is certified as a primary prevention training, so it is largely reimbursed by statutory health insurance companies. And our depression interventions are certified as a medical product. So when we speak about online interventions, there is absolutely no doubt that online interventions are efficacious and can be efficacious. So that has been shown in numerous randomized controlled trials for a variety of psychological problems. But does it also mean that all of the internet-based interventions are effective? That is not always the case. So we have conducted a systematic review and meta-analysis, for example, on stress management interventions in the online sector. And what we have found is that whilst they are being moderately effective, so they are quite good in reducing stress when you take all of the studies together, some of them, and it is actually almost half of them, show non-significant effects. So I think not only from a research point of view, but also from an ethical point of view, I think we should make sure that the interventions that we offer are effective and provide value to the end user. It has also been shown that guided internet-based cognitive behavior therapy is equally effective to face-to-face treatments for example, depression, panic, social anxiety disorder, tinnitus, and but that does not imply necessarily that it works for everyone. So I think we should actually emphasize from the start that participants should have the choice between face-to-face and online interventions. And we also need to make sure that we monitor the routine outcomes of our online interventions. And last but not least, I think it is really important that we take care of how we communicate our online interventions to the end users. It is actually really important that we emphasize from the start that it's not a way or a means to save costs or that it is in any way inferior to face-to-face interventions. And I hope that this discussion panel kind of raises the awareness for the enormous potential that online interventions can have, but also at the same time make you aware of that it's really important for online interventions to work, that we communicate them effectively and correctly within their specific environment. Thank you.
Thank you very much. I think we have several questions, but we would like to address them after the final input statement from another company, from Farina Schurzfeld. She will present her ideas about mental health.
I actually said if my presentations will come up, I'll just dance, but it will come up, I hope. Oh, don't need to press anything. Presentation. They have it. It's here. It's just not there. I can see it, but you guys can't see it, so. I mean, I can start without. That's not a big problem. I start with a quick introduction. That's the second slide. But anyway, I'm Farina Schmidt. I'm the founder of Selfapy, and I think we're all doing similar stuff. I founded an online therapy platform for mental health disorders. And what we started with, we are probably like the little brother or the little sister of the Dutch guy. We started about 2 years ago. And we approached a problem that all three of us founders had faced in a different way. There's a huge treatment gap for depression, which was our starting point in Germany. I'd lived in Australia for 5 years, so you can probably pick my funny accent. And I'd seen over there that the Aussies are far more advanced when it comes to online therapy compared to us Germans, without judging. But because there's a lot of regional areas and they just don't have a chance to actually treat all the people face to face, they obviously developed other methods. So that there's a problem in this market and a treatment gap here with people waiting 4, 5, 6 months to see a psychotherapist, plus a huge stigma around the topic of depression. I think we would all agree to that. There's ways to actually solve this problem is something that was kind of put into our heads and was inspired, I guess, also by my experience in Australia. And what we did is we designed an online program. I actually show you some screenshots in the next slide, but I just want to give you an overview quickly about what we actually do. So we've not invented the word new, like the other guys as well. We've taken a traditional therapy approach and digitalized it. That was my input from Australia. And I was quickly proven wrong that just digital wouldn't work, where this online course, people would start it, but they would not continue until the end. So what we did is like 5% of the people start and continue for 9 weeks. So what we did, we started employing psychologists and work with psychologists to actually guide the people through the digital therapy by talking to them once a week for like half an hour. So we're combining online and offline in a way. For investors, probably less scalable, but definitely more effective. So that's the core, the heart of our product. On top of that, we provide a community, a forum for people to actually talk about their situation, because it is a highly stigmatized topic and it's not something I always go to my best friend and talk to her about it. Especially guys would agree with me that it's not a topic that you put on the table just like that. So we provide an anonymous forum guided by psychotherapists where people can talk about their situation. So that's, I guess, two of the biggest components, and people, while they are in the therapy, can actually track their symptoms so that they see that over the 9 weeks that their symptoms are actually improving. This is just a quick glance of how it actually looks. This is one of our exercises actually when you're in the course. So how you can picture it, easiest to picture for me as an economist and not a psychologist, how I always explain it, it's a e-learning course. So it has elements of videos, it has elements of psychoeducative text, it has elements of audio files, for example. And all these things are combined so that over 9 weeks you actually learn CBT guided by a psychologist, but it's like it's gamified. So it's not as hard as reading a book for 9 weeks, but it's actually a little bit more interactive. And obviously, what we quickly realized that like the topic of depression is one you can tackle, but there's a bazillion other topics that people approached us for. So we 2 years ago started just with depression, but month by month actually launched different topics, different courses, and we're now covering probably half of the course that you are covering. And we're not working with clinics, so our approach is a little bit different. We go to people directly and we go to corporates. So we actually go to employers and say, hey, you're kind of responsible as well for your employees. It's quite interesting for you to actually get started because it's a second reason for people to call in sick, psychological diseases. So why do you not support the mental health of your employee? We've talked about this a lot before. I just want to say quickly, we also did a study. We proved that the guided depression courses actually are as efficient as a traditional psychotherapy, but, and I just agree with the previous speaker here, we're not replacing a traditional therapy. We're offering immediate help, and it's good for light to medium severe depression or psychological diseases, but for severe cases, we're not the right solution. Yeah, I was mentioning that before, so we work with corporates mostly. This is a German quote because I initially thought this presentation would be in German, so I translated it today in the train. But the quote I didn't translate, of one of our happy clients. And yeah, this corporate setup is working really well for us compared to the clinic setup in Germany. I think it's also different markets, the Netherlands and Germany, so we're tackling that. So if you work in a corporate, come and approach me afterwards if you think it's a topic for you. And we're also super clinical, because I guess that's the way to go, especially in Germany. So the courses are designed together with the Charité in Berlin. We've done a study with the UKE. We are a medical product. We've just gotten certified for that. And our board of medical advisors is quite long. So this was quick, but I hope it was insightful. Thank you very much.
Thank you very much for these inspiring presentations. So I think the first issue I would like to ask the discussants is, when it comes to eMental health, often the areas of prevention and therapy are somehow mixed. They are so sorted in routine care, but when it comes to the digital areas, we sometimes do not know, is it what we are doing prevention, primary prevention, relapse prevention of people who have addiction, or are we carrying out therapy? And I would like to ask you, what is your experience? What works better? What is more challenging? You can raise your fingers and speak.
So I'm speaking from a research point of view. What we found is the more severe the symptoms, the better the effects, obviously, from a research point of view, because there's more room for improvement. But what we found when we were implementing the interventions in Germany, we started off with the prevention section because insurance companies were willing to pay for them. So there was a way to reimburse the system. But we found in our projects that we are currently doing a project with the Obama health insurance company, and it is a prevention project in order to reduce depression and stress. And it is aimed at people with mild to moderate symptoms of stress and depression. But we also find that there are people in the program that are actually quite severely depressed. So it is not necessary, because we're targeting prevention, that we also get the people with the mild symptoms, because people normally try to get help when they're having more of a health issue. And what we currently try to do and how we target this issue is that we also include more guidance into the interventions, because that's what we see works best.
Farina, Schurzfeld.
My answer would be it depends, because for us as well, I agree. The people that pay for our courses, it's a self-pay market, right? Of people paying 180 euros for 9 weeks themselves. These are all people with severe, mild to severe symptoms. So only if they really suffer, they're actually willing to pay themselves. Yeah, that's that case. Second case, corporates. I was mentioning earlier I work with corporates. For corporates, the employees it approaches are often more in the prevention sector. Like, these are the people, you offer yoga classes for the people that have back pain. The people that go to the yoga classes are the ones that are actually healthy. And there's a correlation with us as well. Like, the healthier tend to do the prevention stuff. But now comes the interesting, I share a little secret with you guys. It's coming, Christmas is coming up, right? As you all know. And we try to launch something softer also in the self-pay market, because I was like, hey, I actually had this idea at night. I was like, why don't we do an awareness course combined with something tangible, a Christmas calendar? It's just an idea that came up to me, right? We've just doubled our revenue in 1 month doing that. Selling Christmas calendars with the awareness course being like the doors in the calendar, right? So I think you just need to, what I want to say, package it right. Then they take it.
What I find very interesting, if you look at mental health care, specifically in prevention, if you're a clinic, you can do prevention to attract patients, but also help patients who are not necessarily coming into your clinic. So what we try to do is sort of make a filter where patients start with maybe self-guided or self-management, and the ones that don't make it, the system will notify clinicians and they start calling and they reach out. And by doing that, you sort of help the patients who can do it on their own. They use the self-guided prevention and move out of the clinic. But on the other side, you have patients who probably need to go into the mild or severe treatments. And our system uses AI to help you make that decision. The same for corporate. We also do prevention on that side. But then we also work with mental health care providers who provide the next step for the patients who drop out or drop into something different. And I think that that is actually the future if you look at prevention in combination with therapy.
And thank you.
My opinion is that both therapy and self-management are going hand in hand. There are actually some legal differentiation between when is therapy and when is self-management. Our goal is clearly to make prevention doing self-management, because it is, for example, depression, it is illness, and if patients will get a depressive episode, it is a long term of time, and we're really going into prevention in order to give this patients, also supported by our medical doctors, enough information to prevent exactly this depressive situation. Therefore, our goal is to make a lot of prevention.
Thanks a lot. So we have a mixed picture. On the one side, we have a strong focus on prevention, also in terms of reimbursement and paying. But on the other side, you are trying to reach those people who are severely ill, although you always have to also negotiate that you are not working on the severely ill, as we heard from Farina. So this is a big challenge. I would like, because we are now talking on how to reach people, I would like to know, do you have experience that you really reach more populations which are traditionally difficult to reach? For instance, lower socioeconomic levels or rural areas. So do you reach a higher population than which can be reached by traditional care?
I think so too. We did a great experiment where we did a treatment for eating disorders, and what you see with eating disorders, there's a lot of patients who don't turn up to the first meetings, but also they have to keep on writing diaries about what they eat and how they feel and at what moment. And what the clinic saw is that the response rate was quite low, and so they did it on paper. That was how it done before. Once we digitalized it, we started getting calls from clinicians who said, I get so many eating diaries digitally, they're receiving them. That was so much that they couldn't work through the diaries actually. And we started asking what happened actually, and they said a lot of their patients normally didn't fill in the forms, but also they discovered that the patients who normally would drop out of the treatment still stayed on. They also had like social anxiety, so that was combined. So they didn't want to go into the clinic. And actually the digital outreach made sure that these people stayed within the treatment. And that's just a small effect, but great result. Yeah.
Other experiences?
I can tell only talk about the experience of our medical partners. Our medical partners have a portal, and the patients which are suffering by depression can also share their problems, and they can ask questions, and they have really more than 20,000 patients in this portal, which is probably one good possibility. On the other side, because you asked about rural areas or area where the doctors are not so often presented, I think also this new technology can support this, because you are absolutely independent at that point. If you are, you can be in the city, you can be near the hospital, but you can really be also somewhere abroad, and you can have the support.
Yeah, I think online interventions in general are really good to reach people that are normally hard to reach, not only from a geographical point of view, but also, for example, when you think about comorbid diseases, health insurance companies are able to identify people who have, for example, diabetes and depression, and we can also reach out to them, because sometimes they are a bit hard to reach. People do not sign up for these kind of things, and I think health insurance company in general are able. So, for example, we found it very effective to use the membership magazine to recruit participants, because you reach out to a great audience. But also, we quite recently started a project where we target online interventions to farmers. So farmers are living in very rural areas. They might not be able to, go to a psychotherapist, not alone, leave alone the stigma that is associated with mental health for them. So what we've done is we individualized the online interventions to farmers. So we kind of adapted all of the surroundings, the pictures, some of the content. So we kind of kept the core structure that we know works, and then adapted all of the stuff around it, and that really the farmers kind of took it up very positive. And I think it's great that social insurance companies also have an interest into offering interventions for some of those people who are not reached by the traditional healthcare methods.
Thank you so much. Can I ask a further question? I would like to ask, you mentioned where it works. Yeah, and it works pretty well in your companies. When you look at the scientific evidence, you sometimes see some mixed results, for instance, in pain disorders or in bipolar disorders or in schizophrenia. Can you say where it doesn't work? Or in which work areas or in which companies? Do you have fields where you think mental health, e-mental health is not working?
There are definitely some areas where it's difficult. Specifically, if you look at the socioeconomic score of where a person is, Once the IQ is too low or the life is too not structured enough, you're not able to process the information digitally. There are some tricks, of course. You can use video, you can use animations, and there's the great thing is that software is sort of more figuring out who's in front of you, and it's adapting what it serves. So you try to assess based on what people are doing to serve different things. So that sort of compensates a little bit for the fact, but based on our general mental health care population, I would assess that you can do about 80% of the patients. That means 20% not, and that means you still should have the phone and all the normal services. So that's why I believe digital is an addition to your clinic, and it will save you some things, but depending on the population.
Yeah.
I mean, I mentioned earlier what doesn't work, right? We tried digital because my background is digital, and I thought I'll just do a digital product again, right? Because that's what I can do, or that's what I hope I'm kind of good at. But then we launched digital, and only 5% of the people would actually continue the therapy for the 9-week program that we offered. So I can definitely tell you that this is not effective at all. Like 5 out of 100 people, like, everyone would agree with me, right? The results are poor. So now we have psychologists who actually guide the people. So combining this human factor, but that also means we're at a point right now where I think the digital therapies or the digital concepts that are out there can add on to the human factor and what's already there. I don't think, and keep me to it, talk to me again in 10 years, yeah? Maybe AI has gotten us to the moon, I don't know. Not yet. But I think it's a better way of delivering or offering like immediate help, for example, when it comes to therapy. But I don't think a psychotherapist will ever be replaced. I think that's a tough statement, but that's what I
Thanks
think.
for this. So if you have any questions, you can also raise your hands. I think we also need to address data security in this sensitive area. So I would like to know from you, how do you handle your biggest data security problems? Huh? Nobody wants to say something?
I can start. Toughest challenge ever if you're launching a health company. I had to learn that big time. How do we address that? Like, pretty much you start day one and you have a data security person who's consulting you. Like, we didn't do it in-house, so we had somebody externally who would support us. You need the highest security standards that are there, at least in Germany. In Australia, different. In Germany, it's pretty tough. So I can throw some words in here, but you probably have not heard of them. So there is a standard called ISO 27001, which is like one of the toughest secure health data security standards out there, and we're almost there. Meaning, like, the large corporates have the same standard that we have, which I think is sometimes a little bit tricky as well. If you're funding a company and like you have to put all these standards in place, again, it's extremely important. And last note, it's an extremely important topic in general.
Yeah, data security is, of course, a big issue. So we did a couple things. One of the first things we said is, okay, the patient should be the owner of the medical data within the system. So the provider is providing a healthcare service, and the patient will have full access and insight and owns the data, actually. And the healthcare provider has a copy of it. That's what we did first. The second thing we needed to do was build an encryption engine. So what we wanted to do is, if you store mental health care information, it's so personal. We wanted to have real-time encryption of all medical data that is stored on the servers, because normally when you build online software, people can read the databases. We build security by design, so our company is not able to read the databases only by... so we use an event engine to sort of use the data on a different sense, but we cannot read what somebody's doing. For the rest, of course, you have all the rules like the ISO 27001 and 01 and so on. And for the rest, you have the GDPR coming in. So it's a big hassle. So you need to employ a lot of developers to keep your security up and running. And that's what we do on a daily basis. We do updates every week. We work with more than 20 developers to do it. It's tough.
And you wanted to make a comment?
Yes, in our development, the main issue is that the patient should be owner of his own data. If the patient wants to share his data, he can share the data. If not, not. he can share the data with his doctor or not, but he has to get this possibility to share the data or not, and also to choose which data the patient should share. So in order to realize this, as told already by my colleagues, we have to fulfill all the standards here. It is a difficult issue. We work together with Adesso, which is a company working previously with insurances, and they have these all standards, but our data have the important anonymization, everything. But I would like to make another point. It is very difficult to work with sensors. Why is it difficult to work with sensors? Most of the sensors are not developed for the European market. Most of the sensors are not developed for Germany. That means if you acquire data, these data are sent firstly to back-end server somewhere in the world, which is not allowed. So it is very difficult to find the important data, the important and the sufficient sensors where the companies producing these sensors will allow you to access the data on the sensor or in the smartphones, and not firstly where they are somewhere in the United States and ever. And I would like to say, if somebody would like to work on this topic, has to be really, really very carefully exactly about application of sensors in mental health.
Thank you for reminding us about this issue of integrating physiological data. There is a question from the audience.
Yeah, thanks a lot. I'd like to know, regarding to the title of the discussion with new applications, which new technologies do you see like artificial intelligence?
But we can guess.
If I understand correctly, you asked a question of new technology in mental health care, which are arriving. Good question. You see some VR treatments, of course, for depression or actually anxiety, exactly, yeah, like anxiety, flying fear, stuff like that. So you see some great results, but it's also still in the very early stages. If you look at AI, you see a lot of chatbots who do like automated therapy. But there, of course, the context is still the problem if you look deep below. We did some interesting research on a group of patients who get like a structured patient journey. It was 1,000 patients, a data set about 2013. They all got the same addiction therapy, combined digitally and all. And we built an AI to predict the dropout rate during the treatment, and we were able to reach about 80% certainty on the dropout rate. So if you digitalize processes, we can do great things. Yeah.
One final comment from you on this?
Yeah, we are, for example, building an algorithm to actually tailor like therapy for your particular situation. Like that's an example. So you are depressed, but you have a daily routine. You have, I don't know, you just became a dad or whatever, and it would tailor towards your needs.
I think these are some of the applications, but I think there's plenty of time. Each of the discussants will have some figures. I think most of us can be more innovative, but I think we've seen that we have already to tackle a lot of issues in the practical areas. So thank you for your nice and informative input. And I think we have seen that this is a good way forward in the area of e-mental health prevention and e-mental health therapy. And thank you for your audience, and you can use the final minutes to come to the discussants and ask specific aspects. Thank you very much.